Infections of the genital tract come in two forms: the lower genital tract, which is the vulvovaginitis, and the upper genital tract, cervicitis, PID, and tubo-ovarian abscess. They're very important to separate in your mind because the lower tract is caused by certain organisms and upper tract by different. So let's start by dealing with vulvovaginitis first. Inevitably, the question about vulvovaginitis is going to give you a condition, a woman who's complaining of vaginal discharge and itching. And what you're going to have to do is separate the bug and the treatment based on what the patient presentation is like. That is, what is the discharge like? What does the micro show you? What is the pH of the discharge? And then again, how do you treat it? The first bug is Candida. Candida is a fungus. What you'll see is a sticky white discharge that is adherent to the vaginal wall. It is usually found in a patient with diabetes who's on steroids or recently finished antibiotics. They're going to have a risk factor for developing a Candida infection. And now every patient with discharge from the vagina, you're going to do a wet prep. A wet prep is both a KOH prep and a saline prep. You take one microscope slide, you take a drop of KOH on one side of the slide and a drop of saline right next to it, and you're going to smear the discharge into both. Put a cover slide on and look at it under the microscope. KOH prep and saline prep, every patient, every time. Because on a KOH prep, you will see the pseudohyphae. Diagnosing it as Candida. To sort of support you, Candida has a normal pH of about 4, unchanged, where the other two we're going to talk about have elevated pHs. And because Candida is a fungus, you're going to use antifungals, such as fluconazole. And you're always going to try topical, that is vaginal, before you try PO, as a general rule as we go down. The next bug is Haemophilus, also called bacterial vaginosis. This is simply an overgrowth of the normal vaginal flora. The patient is going to complain of a fishy odor. And this fishy odor is made worse with an application of KOH. It's called the whiff test. It will be a gray-white discharge. This is a perfect example of why you do both KOH and saline prep every patient, every time. The KOH prep exacerbates the fishy odor and is a positive whiff test. But in order to see the organisms, you need a saline prep. Because the saline prep is going to show you the clue cells. Clue cells are normal vaginal cells covered in bacteria. This is diagnostic for Haemophilus. The pH of Haemophilus is a little elevated. It's a little more alkalotic. This is treated with metronidazole. Again, topical, before you try systemic PO. The final bug of vulvovaginitis we're going to talk about is Trichomonas. And Trichomonas will be described as a yellow-green and frothy discharge. It is an STD, so you'll likely see the patient ping-ponging. That is, you only see the girl who you treat for the STD. She comes back again with Trichomonas again and again and again because you're only treating her. Her boyfriend has it and keeps giving it back to her. So this is the only one you'll see the patient ping-ponging or the disease ping-ponging back and forth between treated partners. Again, you're going to use the saline prep. What you're going to see is flagellated organisms that are motile. They're zipping all over the slide. This is also basic and is also treated with metronidazole. But unlike the others, you're going to use PO and you're going to treat both partners at the same time, even if one is asymptomatic. If partners are sleeping together and one of them has trichomonas, the other one has trichomonas too. So in general, what you're going to do for a patient complaining of vulvovaginitis, every patient, every time, is do a speculum exam. And from that speculum exam, you're going to get a wet prep. The wet prep is both KOH and saline. If you see the causative organism, simply treat it. If you don't, get a culture and treat what grows. So this is infections of the lower genital tract, vulvovaginitis. Let's move over and start talking about infections of the upper genital tract, cervicitis and acute PID. And start with cervicitis. Cervicitis is an infection of the cervix, and it is essentially caused by STDs, primarily gonorrhea and chlamydia. The patient is going to present with cervical motion tenderness. There will also be a cervical discharge. But unlike in acute PID, it's not so severe that there's a fever or leukocytosis. There's no abdominal pain. She may feel a little bit of pain with sex, but unless you did the exam, she may not even know she had an inflammation of her cervix. So it's fairly mild. The diagnosis is made on physical exam. But if you want to be sure what the causative organism was, you can get a gonorrhea and chlamydia PCR. If there's any sort of discharge, you're also going to do a wet prep. These are not necessary to do because it's so often caused by gonorrhea and chlamydia, and they travel together. You're just going to treat them both. You treat gonorrhea with ceftriaxone, one-time dose, and you treat chlamydia with doxy for 7 days. If you see cervicitis, you presume it's gonorrhea, chlamydia, you treat them both. If you want to be sure so you can tell her what she had, get the PCR. Now let's step it up in acuity. Cervicitis that's really bad is called acute pelvic inflammatory disease, acute PID. The pathology is the same. It's an STD, usually gonorrhea or chlamydia. Only now the patient is sicker. She is going to have cervical motion tenderness, but it's more than that. It's more peritoneal. It's peritonitis of the vagina. It's said to have a chandelier sign, such that when you touch the cervix, she jumps for the chandelier. It's that painful. She is going to have discharge, but now it's going to be severe. She's going to have fever, a leukocytosis, and abdominal pain. The diagnosis is again clinical, and you can get the gonorrhea and chlamydia PCR to be sure. But the treatment is the same. Most patients do not require inpatient management, and you can treat the gonorrhea with ceftriaxone and the chlamydia with doxy. But if you have acute pelvic inflammatory disease, and it happens a bunch of times, what you do is you weaken the cervical lining. You let vaginal flora gain access to the uterus, to the fallopian tubes, and to the ovaries. And you can present with chronic pelvic inflammatory disease. Or more appropriately, you can set up the tubo-ovarian abscess. This is essentially vaginal flora that has gained access to the normal sterile uterus. And the patient is going to be sick. They're going to have the cervical motion tenderness of acute PID. They're going to have discharge, fever, leukocytosis, and abdominal pain. The diagnosis is made by feeling an adnexal mass. It's more than just cervical motion tenderness. So when you find the adnexal mass, you get the ultrasound. Tubovarian abscess is covered in the lecture of adnexal masses. the ultrasound will be complex and show you the abscess. The difference in presentation being the presence of the adnexal mass. The pathology being different in that it's now vaginal flora that have gained access to a sterile environment. Because it is vaginal flora, the treatment changes drastically. You're going to start off with metronidazole and a fluoroquinolone. You can also use ceftriaxone, doxycycline, and probenecid. If antibiotics improve the condition and make the abscess better, you continue antibiotics. However, if she fails to improve, you need to go in and drain the abscess. All right, we're going to finish with one more infection that's not really an infection at all. It's toxic shock syndrome. Toxic shock is caused by Staph aureus secreting a toxin and is caused, Staph aureus sets up shop when tampons are left in too long. These patients are suffering not from an infection of Staph aureus. The infection is on the tampon, but they are secreting a toxin that produces the syndrome. These patients are sick. They have a fever greater than 102. They're going to have nausea and vomiting, maybe some diarrhea. But the thing that separates toxic shock syndrome for all of these other gynecologic infections is the rash and desquamination. There's going to be an erythematous macular rash. And there's going to be desquamination of the palms and soles. There are not many diseases that desquaminate the palms and soles. And so if you see this or hear this in a test question, especially in an OB question, guaranteed to be toxic shock. If you perform any diagnostic tests like blood cultures, they're all going to be negative. So don't forget the speculum exam where you're going to find the tampon, because that's how you treat it. You have to take the tampon out, treat the staph, which is going to be with nafcillin, unless you live in an area endemic for MRSA where you're going to start with vancomycin. But that's not what's causing the symptoms. Remember, it's the toxin, not the infection. So you're going to have to give her intravenous fluids and support her, generally in an ICU for monitoring, to get over the toxin until she clears the toxin. Okay. So we have had two types of infections. The lower genital tract vulvovaginitis, Candida, Haemophilus, and Trichomonas, treated only with PO antibiotics and diagnosed by wet prep being KOH and saline. And then we had the upper genital tract infections, cervicitis, acute PID, tubo-ovarian abscess, and toxic shock, presenting as a much sicker patient needing heavier duty antibiotics, but generally not needing any diagnostic intervention except in the case of a tubo-ovarian abscess where an ultrasound rules in the abscess. That is gynecologic infections. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.